Okay, so this week we are going to be starting pediatrics. Personal favorite of mine. I did pediatrics for about 20 years, so I really enjoy this practice setting. So we're just going to go over some of the concepts that are important and relevant to pediatric nursing. I have everybody on mute, but if you do have a question, please feel free to unmute yourself and ask your question. I do my best to keep an eye on the chat, but I don't always catch it. I will be checking it after class is over, and if there's any specific questions that I see in there, if it pertains something that everybody is going to need an answer to, I will post that to an announcement. Otherwise, if it's something specific to a certain person, I will send that to you as a course message, as I do try to get your answers. Okay, here we go. So an important concept with pediatrics is family-centered care. So make sure that you review that concept because that's going to be very important as we go through our pediatric population. Families should be a constant in the child's life. They should be something that the child can rely on, and that's not always the case, sadly. Sometimes you'll interact with a child that comes from a broken home, maybe from divorce, or maybe from an estranged family. They're living with relatives. They don't live with their parents anymore or their siblings. So that's always something to be aware of. But family really should be a constant in the child's life. Remember, we talked about way at the beginning of the quarter that family is whatever the person says it is, and in the pediatric population, that's no different. It doesn't have to be the family that they're born into or their biological family. It can be the family of choice. It can be a situation where the one of the parents gets remarried and the person that they marry has children. And that's a very common theme in our culture today. The blended family, that's very, very common. You'll come across that if you decide that you want to work in the pediatric practice setting. You'll see that a lot, where you have the two adults who have children of their own, and then they get married and they form the family of their kids together. And sometimes maybe those two may have a child of their own that is added to the mix. Maybe they'll have more than one. It really just depends. But the bottom line is family is whatever the person says it is. Who do they identify as family? It could be neighbors. It could be other children. If you're talking about a homeless situation where you have children living on their own in their environment, they could form a family with other children who are in the same situation as they are. Positive family relationships. This is characterized by that relationship between the parent or caregiver, doesn't necessarily have to be the parent, and the child. And the hope, of course, is that it's positive. But this is part of what we're looking at when we're dealing with families. We have to form a partnership with the family, not just with the child, but with the whole family. Because it's not just the child that's your patient, it's the whole family. That's a different way of looking at nursing care as opposed to the med-surg part when we talk about patient-centered care, and we want the family to be part of their care. We want them to be involved. But this is very, very different. It's the whole family is the patient, because what affects the child affects everyone that the child is involved with. We have to make sure that we're respecting cultural diversity. If you think back to when you first started the program, we talked a lot about culture. We talked a lot about integrating cultural health practices and beliefs into their care. It's very important that we're respecting that cultural diversity, because there's lots of cultures out there who have a different way of rearing children and of bringing children up, and different traditions that are part of their parenting. So we do need to have some understanding of that. Treating the family as the client. Very, very important. Any questions so far on any of that? Hopefully that's starting to maybe jog some memory, bring back some information from way back at the beginning, like week 1, right? We're really going back. But that just goes to show, that stuff doesn't go away. It does circle back. Okay. So what's our role? What's the nurse's role when we're talking about the pediatric patient? Obviously, we need to establish that therapeutic relationship. So make sure that you are reviewing what is a therapeutic relationship, what does it mean to therapeutically communicate. It's very, very important that we are communicating therapeutically, not just that we're providing them with education, not just that we are explaining procedures and letting them know what to expect, providing that anticipatory guidance. We need to do it therapeutically. There's always a right and a wrong way to communicate. And it's very important that we are doing our very best to communicate in the right way, that we are providing that supportive and empathetic communication, right? That we have an open dialogue. We need to establish that trust. Otherwise, why would they even bother communicating with us? If they don't trust us, then there's no reason for them to communicate with us, right? Again, the whole family is your client. So everybody that is involved with the child, it's important to make sure that we're integrating them in. Parents are the experts on the child. That is so key to pediatric nursing. And I think sometimes this gets overlooked by certain providers. It's very frustrating as a pediatric nurse. It was always very frustrating to me that when the parents would be communicating what was going on and why they were concerned, the provider, they would have their own ideas and thoughts about what was happening, and they really weren't listening to what the parents were saying. And that's always a mistake because they're the experts. Those of you that have kids, I bet you could sit there and be in the same room with your kid and know just from talking to them or observing them if they weren't feeling well or if they were sick. Mine are all grown, and I can tell you, I still know when they're sick. All I have to do is look at them, get that first glimpse of their face, and I know immediately that they're sick. And I'm sure a lot of you that have kids could say the same. So why wouldn't we listen to them? They are the experts. They spend all their time and energy with that child. Why wouldn't we listen to them? And it's very frustrating as the nurse when the providers don't do that. So we have to be the advocate. We have to get the provider to listen. We have to intervene if necessary and say, this is what the parent is saying. I think it's really important that we pay attention to that and listen to that. Allow the child choices where it's applicable and where it's appropriate. That's going to be very important as well because children don't get a lot of choice, especially small children, school-age children. They don't get a lot of choices, right? They're told a lot of times what it is that they should be doing. But if it's applicable and as long as it's appropriate and not contraindicated, there's no reason why we can't give them simple choices. That's going to make them feel involved. That's going to make them feel like we are listening to them. A kid wants to be listened to. Adults a lot of times talk over the child, not to the child and not with the child. We talk over them because, oh, well, they're just a kid. What do they know? Well, they know themselves. As they're getting into that school age where we're getting into middle school, right, approaching those teenage years, they know themselves. They know how they feel, right? They're the one that's feeling the pain or the upset stomach or the nausea. And, they know how they feel. So it makes sense that you would want to listen to them, okay? And you want to individualize the care for them. It can't be cookie cutter or garden variety, one size fits all. That definitely doesn't work with pediatric nursing. So we do have to individualize that care to that child, to their specific needs and their family's needs. Does that make sense for everybody? Anybody have any questions on our role? No questions. Okay. All right. We'll keep going then. Okay, so a very important difference with pediatrics as opposed to med-surg or working with adults is how we interact with the child, how we do our assessments, because we have to alter our assessment techniques based on the age of the child. That's very, very important. You're not going to interact with a toddler or a school-age child the same way that you're going to interact with an adolescent, because they're at a different age, they're at a different developmental level. So it wouldn't even make sense to try to approach them in the same way. So it needs to be age appropriate, okay? We have to make sure that we're including the parents or the caregivers. It's very important to make sure that they're part of it, because again, remember, they're the experts, so they need to be involved. Observe behaviors, especially with really young children. You're always on the lookout for those nonverbal cues. What's going on? Because they can't always communicate very effectively to us. As they get, preschool, as they're getting into school age, they can communicate better, but they still lack that ability to really effectively communicate what's going on with them. But if we're observing their nonverbal cues, we can see if they're frustrated. We can see if they're angry. We can see if they're scared. So that's what we're observing for. And we have to remember that an infant cannot communicate verbally with us. They only communicate through their behavior. So we definitely have to be observant for that behavior. Language, cognition, and motor development definitely come into play for our assessments. And that's how we tailor our care to be age appropriate. Okay. Some of the considerations, obviously, the environment is going to be very important, making sure that it's as non-threatening as possible. Remember, we're strangers to them, so they're going to be scared. It doesn't matter how many decorations you put on the wall, the cute wallpaper, the paint, whatever, that doesn't matter. It's still a strange environment for them. But we try to make it as non-threatening as possible. Make sure that there's plenty of lighting, because if you're in a doomy, gloomy room, that is very intimidating for them and it's going to be scary for them. So make sure that it's well lit. And keep the medical equipment out of sight unless you need it. You don't want to drag all your stuff into the room. Maybe keep your stethoscope in your pocket. If you have to do vitals, you just bring the vital machine with you. Don't have a lot of equipment with you, because they're very intimidated by that, because the thing that the kid fears most is pain. They're afraid of pain, especially if they had to go through the emergency department to get to you. They've already had all those painful procedures done down there. They've probably had, blood work done. They may have had an IV done. They've had to have x-rays done. All of that stuff is very scary for them, but they fear pain. They fear being hurt. So you want to make sure that you're keeping the equipment out of sight unless you need it. Don't let them focus on that, okay? And you don't want to just charge in and start poking at them either. Take some time to interact with them, talk to them, talk to the parents. If the parents trust you, the kid is going to trust you, or at least they're going to say, they can't be that bad if my mom and dad are talking to them, because mom and dad is their protector, right? So if mom and dad is willing to talk to you and interact with you, the kiddo is going to be a little bit more reassured that you're not a bad person and that you're not going to hurt them. Make sure that you get down to their level. That's very important. Don't be standing over them. I mean, you're a giant to most of these kids, right? Especially with a really young, really small child. So you don't want to be standing over them just looming like a giant, because that's very frightening to them. So make sure that you bend down, that you get down on your knees maybe, and so that you're making direct eye contact with them. Always interact with them directly. Don't talk over them, but especially with the really small children, toddlers and preschoolers, it's very, very important. You want to establish some sort of rapport with the parents first. Make sure that the parents are in the room. You don't want to be interacting with the kid without the parent or the caregiver or someone that they trust to be around, because that's, again, going to be very scary. So if at all possible, make sure that the parents are around. Let the parents hold them while you're doing your examination. There's no reason why they can't hold them. You don't have to take them away and make them be on the bed or make them be on an exam table or whatever the case may be. Let the parents hold them. That's going to be reassuring to them. Again, the parent is their protector. Their parent is not going to let somebody hurt them. So let them sit in the parent's lap. It's okay. It's not going to interfere with anything. You do your assessments with a child as far as how you do the assessment is the same. It's head to toe. So you're starting off with the head, and then you go to the chest area, and then you go to the abdomen. You're looking at the extremities. You're watching how they move. You're watching how they communicate. All of that is the same, but it's the approach that is different. In the picture here on the PowerPoint, you can see how this nurse is interacting very positively. He's got a nice smile on his face. He's letting her hold on to her stuffed animal, and he's really interacting with her. He's at her eye level. He's not standing over her. Very, very important. How you talk to them is important. Now, you don't have to do baby talk. You definitely don't have to do that. But just using a very mild tone of voice, not being very overbearing or very stern, you know, making sure that you have a pleasant demeanor when you're interacting with them. You need to be as non-threatening as possible, because this is a very scary environment for them, very scary, and they don't really understand what's going on. And of course, like I said, they fear pain. So letting them take a look at the equipment, maybe letting them hold your stethoscope, take a look, say, this doesn't hurt. In the situation with this child here, I would probably put the stethoscope on the bear and say, see, it's just, it doesn't hurt. I'm just putting it here, that's so I can hear their heart, hear their breath. You can let them put the stethoscope in their ears and listen to your chest, or listen to mom's chest or dad's chest. Let me tell you, you let a little one like this have a stethoscope, they're going to be listening to everybody. It's going to be like, try to make it like a game for them. That way, then they're not afraid of it. And every time you come in with your stethoscope, they're not going to freak out. Oh, it's just the stethoscope. I remember that, because kids do remember. Any questions on assessments? Does that make sense, guys? Oh, thanks. Thanks, guys. I just want to make sure I'm not by myself in here. Everybody's kind of quiet today. Is it just because it's Monday? Okay, so some of the things that could potentially interact or affect your assessments, your interactions with the child, have to do with parenting style. So we're going to kind of go through parenting style a little bit. If you go back to chapter 3, page 65, that is definitely in some important information. It kind of goes into more detail on parenting style. I'm going to go through some of these, and feel free to give me your thoughts on it. If you have any personal experience or you've experienced these types of parenting styles in the past, feel free to just talk about it. I like interaction, so I don't like feeling like I'm by myself in here. Dictatorial or authoritarian. Everybody knows this style. This is the do as I say and not as I do. They're very strict. They have very strict rules, and those rules must be followed. There's no negotiating with this parenting style. There's punishment that would be involved if rules are not followed. Sometimes this parenting style might do more corporal punishment, giving spankings or things like that. So that's definitely something to know. These children might be a little more shy. They may not be as interactive with you because they're kind of taking their cues from this parent, because this parent runs the show, right? So behavior is dictated by this parent. So they're definitely going to take their cues from their parents. They probably won't speak unless spoken to. They may not be or they might be more withdrawn in some cases, depending on that parent. Or they may be afraid when that parent is in the room. It could be one parent. It could be both parents. It really just depends. But this type of style can definitely affect the interaction with the child, because they're they have complete control, and there's lots of rules, and those rules absolutely must be followed. There's no exceptions, none. The permissive style, or what they call the laissez-faire, they don't exert hardly any control over the child. These are the ones that you see in the grocery store that are running everywhere, and you know that you're in a restaurant and they're climbing all over everything, and the parent's just sitting there, and you wonder to yourself, how can that parent just be sitting there? Well, they don't exert a lot of control. The kid pretty much runs the show. They decide how things go pretty much, and the parent is not really much of a figurehead at all. So, and they'll consult the child before they make any decisions to make sure that it's okay with them. Democratic or authoritative, these are your parents that will bargain, they will compromise. There are rules. It's not that there aren't any rules, and there are, I don't want to say punishments, but they will take away privileges if the rules are not followed. So if you have a child that has, they're supposed to be going over to a friend's house to play, if they don't follow a certain rule, then they probably will not be able to go to that friend's house. They'll be, grounded. In other words, you guys remember what that was like, some of you, I'm sure, when you were growing up, how you got grounded, or maybe if you had a cell phone, that cell phone was taken away, or if you had a certain activity that you really enjoyed doing, that would be taken away because you didn't follow the rules, or whatever the case may be. If you're talking about a really little child, this type of parent would probably give them a timeout. Go stand in the corner for a little bit. Not that that ever works. I personally don't think the timeout works, but I mean, that is an accepted form of punishment for a really, really small child. But it's important that there are rules. It is important that parents guide their child's behavior, because there is acceptable behavior and there's unacceptable behavior, and it's the parent's role to teach the child about that. It's very, very, very important. Oh, Ron says he remembers the taste of zest. Yes, that my mother did Lava Boy. If you've never had to have that in your mouth, let me tell you, it's zest tastes pretty good. Your passive parenting style. Now, your book doesn't specifically mention this one, but I believe your ATI book talks about it. Your passive parenting style, they're very uninvolved. Basically, they are the ones that are important, not the child. The focus is always on them, and they don't really care what the child does or doesn't do. They don't really exert any parental authority over the child whatsoever. And this can affect the child's emotional health. If you want, I mean, kids like to have their parents involved in their lives, and when the parent's not, and when the parent obviously shows that whatever's happening with the parent is more important, that does affect the child's emotional health. So these kids would definitely be kind of withdrawn. They will definitely act out more. They'll definitely more prone for misbehavior because they're trying to get the parents' attention. Kids crave attention, whether positive or negative, and this type of parent doesn't give attention. So they will definitely be the type to act out more because they crave the attention. Even though you might think that, oh, well, this would be the perfect environment for a kid. They don't want to have rules. They actually do. They like rules. They like structure. They like schedules. And when any of that gets disruptive, kids don't like that. It's something that I've learned in all the years that I've been working with families. It really is very important for them to have rules, to have structure, and to know that that their parent really does care about them. This shows that their parent cares when they have structure for the child, when they do have rules, when they're guiding their behavior. This really does show caring. Not that a dictatorial parent doesn't show caring. It's just that they're very focused on rules, and that's what they think is best. is that they enforce those rules in order for the kid to learn what's right and wrong, and that's really what their focus is. But it doesn't mean that they don't care. And yes, someone brought up there could be a mix. Yeah, there could be. There could definitely be a mix. My parents were a mix. My mother was the dictatorial authoritarian, and my dad was definitely the democratic. He could negotiate with you, he could compromise. My mother didn't understand that thought process. And that goes to what was their life like. Her growing up, her home that she lived in was very authoritarian. So it made sense that that is how she would parent, or she would think that was the right way to parent. My dad's home life was not like that. My grandparents on my dad's side were more negotiate, more compromise, which was unusual, but that's kind of the home life that he came from. So when you put the two together, you definitely have a mix. But a lot of times in that type of home life, the dictatorial parent may or may not exert more influence over how things go than the democratic or authoritative parent might. Renee says, some days were spankings, some days were groundings. Yeah, I can't say that I ever had to experience spankings, but I definitely went through some groundings and my favorite activities taken away, especially when I was in middle school, getting into high school. I used to go roller skating a lot, and that would get taken away because my mom knew how much I enjoyed roller skating, so that was the first thing that would go, was the roller skating. So I made it a point not to misbehave. And of course, I had older siblings, and I had one younger sibling, and I made mental notes, okay, I'm not doing that. Look what happened to them. So you kind of, when you're almost in the middle, almost to the tail end, and you've got older siblings and a younger sibling, you kind of learn how to negotiate the waters, in other words. Any questions at all about parenting style, guys? Is that making sense? It does affect how we interact with the child. And part of our assessment is to observe how this family interacts. How do they interact with their child? How does the child respond, to that interaction? Are they constantly raising their voice to the child? Are they constantly telling them, don't do this, don't do that, stop that, sit down, be quiet? A lot of times your dictatorial parenting style would be children are seen and not heard. That's pretty classic. So is this the type of situation that you're walking into? Because you need to be aware of that so that you can try to help and try to be supportive as much as you possibly can. Obviously, you're not going to change the way they parent, and that's not the goal. The goal is to help in any way that we possibly can, to provide that support, to make sure that we are establishing that therapeutic, trusting relationship and providing the information that the family needs. Because if you're dealing, and it also depends on what environment are you dealing with them in. Are you in the clinic where they're coming in for a well child visit, or are you in the emergency room where the child's been injured in some way and the parents are bringing them in, or they've been sick and the parents are bringing them in? Or are you dealing with them in, they're being admitted to the hospital, because hospitalization causes a lot of stress. So that can also affect some of that interaction that you may see. So that's definitely part of your assessment and what you're looking for. We have to know how that family communicates. Okay. Any questions on parenting styles? Please make sure that you review this information, because you're going to need to know this. It's going to be important. So make sure that you review it. Okay. All right. So I always like to talk about health promotion. We're all about health promotion as nurses, right? We try to prevent illness from taking place. So we gear our education for our families and for our patients toward health promotion. So, well child care, bringing them in for regular clinic visits. When they come for their visits, we weigh them, we're measuring them, we are talking to the parents about different milestones. Has your kid hit this milestone or that milestone? Growth is the best indicator of their nutritional status. Are they gaining weight? That's the best indicator. Immunizations, I put a little figure in here for you guys, figure 4-1, page 93. You could also go to the cdc.gov, so make sure that you review the immunizations because that's also going to be important, especially for that first 12 months. Focus on the first 12 months because that's when we immunize the most, is the first 12 months. So those are the ones that you want to focus on and that you want to review because children don't have an established immune system until they're about 5 years old because we don't have memory cells. We need those memory cells in order to establish an immune system. Well, we don't develop those until we're about 5 years old. So that's why young children are given so many frequent immunizations because they don't have that established immune system. Now, there can be a lot of controversy surrounding immunizations. There's lots of parents out there who have issues with immunizations for lots of different reasons. Sometimes it's they fear the additives that are in immunizations, or they may have heard something or read something online, or they, were told something by friends or neighbors or whatever the case may be. So that's just something as the nurse to be aware of, that there could be some controversy around immunizations. That doesn't mean you don't provide the education. You definitely need to provide the education about it. Is it a perfect system? Absolutely not. But it's the best system we have right now to protect our children. And when parents don't immunize, that puts the child at risk for a lot of those communicable diseases, things like measles. You didn't really see measles much in my practice, especially when I first started. I mean, I never had seen a case of the measles because that was part of the immunizations that we gave. But now you've got parents out there who are not immunizing, and so now you will see measles, and that's deadly. That's deadly, especially to a baby, to an infant. Measles are deadly. So, it's just something to educate. You're not going to convince them, and you don't want to approach your education as I'm going to convince them to do this. That's not what you want to do. You're educating them to give them the best information possible. Again, this is not a perfect system, but it's the best that we have right now to provide protection for the child, because you don't want them to get those devastating illnesses like measles. Okay? Car seats. Very important. They need to be at least until they're 90 pounds, I believe, they need to be in car seats. Now we are required to have car seats until they're 2 years old. So, now when they get to be toddlers, they can figure out ways to get out of the car seat. So that's definitely part of the education that we provide. When they come in for those well child visits, we have to educate them about, the kid can get out of the car seat. My kid was always able to get out of his car seat. I'd be driving, and the next thing I know, he's looking at me in the rearview mirror. So just, they're magicians. They figure out, they watch. You think kids don't watch what you do? They watch everything you do. And they're pretty quick to pick things up. So, but just something to be aware of. It's law. It's right. It's very, very, very important. So hand hygiene, as my picture says, we want to make sure that we are educating them about hand hygiene, making sure that the parents are educating their kids about hand hygiene, right? Because that's the best way to prevent the spread of infection is by good, clean hand washing. Parents and siblings, making sure that they are involved, right? This is a family adventure. Adventure. It's probably not the best term for it, but wanting to make sure that they're all involved, that, because Even the siblings, sometimes the siblings might feel a little bit of rivalry because their sick sibling is getting all the attention and they're not. So maybe you could take a little time to talk to them and interact with them a little bit. You know, find out how old they are, what grade in school they are, what kind of sports do they like. You know, that's okay. That's kind of makes them feel like they're not being left out. Because when a kid is sick, a lot of times his sibling might feel like they're being left out because now that sick child is getting all of the attention. Any questions on health promotion, guys? Okay. All right. The next concept I wanted to just touch on is therapeutic play. Play is a very important part of childhood, and it's not just because it provides them with a distracting activity. It really helps them to develop and to modulate their behavior. It teaches them how to interact in a group. It teaches them acceptable behavior over unacceptable behavior. It encourages them to act out their feelings. It's a very important part of childhood, making sure that they have that opportunity to get out their feelings, because that's what they do when they're playing. And if you're observant and you're doing your assessment, watching them while they're playing, you can get a lot of really valuable information from that interaction. Safe environment to practice coping strategies, right? To really learn how to develop some of those coping strategies, because it's difficult. And they're very useful in medical treatments. There's child life specialists in some of the facilities. Not all, but some have child life specialists, and their role is to really help the parent and the child to navigate the hospital environment. They provide a lot of education about what to expect during the hospitalization. Maybe they're going to have surgery, so they'll provide a little bit of education about the surgery and what to expect after surgery. They have an environment with a lot of different toys to be adequate for different age. So, and they're very focused on the developmental stage of the child. So they want to make sure that everything that they're doing is age appropriate. Okay, so I have a little video here I'm going to turn on for you guys that kind of gives you a little bit of an idea about that. Okay, here we go. Now let's hope this works today, guys. I've been doing pretty good with this all quarter, so I'm assuming it's going to work. Let me just unplug myself.
Having a child life specialist in the hospital can help improve the patient's experience by making sure that it's less traumatic. We're here to make sure that the children are comfortable or lessening their anxiety, their fears, their stress. I always start my interventions that there's not going to be any secrets. So no matter what we do, you and I are going to talk about it.
My day is different every single day. You never know what you're going to come into, but I know that every day we're making an impact on children.
We see children birth to 17 years old, and so you need to know those developmental stages so that you can actually assess the child for what they are, maybe what they're needing in the hospital. I actually recently started a program in same-day surgery. So on Wednesdays, and I get to help the kids come in and we prepare for procedures. And we also just started a same-day surgery tour program, so they can schedule a tour prior to their surgery. Usually they respond super well. They're super excited to see the OR because they can see it in TV shows and they hear things maybe from friends.
We have a pretty stringent requirements to get into the profession. But I think outside of that education, you also need to be a big kid yourself and like to be able to play.
We are taking care of a parent's most important possession, and therefore we're going to treat that child like it is that parent's most important possession.
Child life is an asset to doctors and nurses. Sometimes easier for the child to tell the child life specialist some things, and we are like a patient advocate. They've had to use less sedation medicines, which is amazing because the child will be able to use their coping skills that the child life specialists are providing with them and practicing and use them to get through the procedure.
I was able to prepare a patient for her port. She was going to be having a port placed, and she was very nervous about it. And so she was going to be having a G button placed too. So I was able to give her a doll. The doll had a G button, and so we just got to talk about it, and I got to teach her, and then she got to use her doll to play with the G button, see where the port was going to be placed, and now to this day, anytime she's admitted, she actually starts IVs on her doll.
They're in and out of the hospital a lot. Just giving them something different to do when they're here that they haven't done before is kind of exciting.
We spend a lot of time getting to know their family, their siblings, them, and it's just almost like a family aspect that you're just a second family to them.
I love the kids. Every day is a different day. Every child is different. Children are so different when they are in the hospital than other places because they're not feeling well and they're just vulnerable, but also so resilient.
Okay. All right. Oh, yeah, I got to pull back up my PowerPoint, don't I? Okay, guys, so any questions on therapeutic play or the importance of play, the impact of play, the role of the child life specialist? As I said, they're not in every facility, but if you're lucky enough to be in a facility that has them, I definitely would advocate that you use them because they are a great resource. Hospitalization is very stressful, not only on the child, but it is very stressful on the family. The thing that I want you guys to remember is in this specialty specifically, what affects one member affects them all. So if you have a child that is sick, it's going to affect the entire family. It doesn't just affect the child. It doesn't just affect the parents. It's going to affect everybody. So that's very important to be aware of. And a child life specialist can really be a wonderful tool that you can use to kind of help the adjustment of the hospitalization or whatever the situation may be. I mean, it could be that they're coming in for an outpatient procedure and the child life specialist can take a little bit of the load off of you to go in and talk to them about the procedure, talk to them about what to expect, maybe what the OR is going to be like, maybe what the recovery room is going to be like, maybe some of the equipment that they're going to be using. It's very terrifying because this is not something that they're ever had before. Maybe sometimes you might come across a child who's been in the hospital a lot. Unfortunately, maybe they've had a lot of health problems growing up, but that's rare. Most times the kids that you see in the hospital probably have never been in the hospital before. And this is a very scary time for them and scary for the parents too. So a child life specialist can go a long way to helping you. Now, most pediatric units have toy rooms. So if you don't have a child life specialist, you could always take the child to the toy room and spend some time letting them, as long as they're not on isolation, they should be able to go to leave their room, take them into the child or the toy room and let them spend some time playing with the toys and really observe, because you'll get a lot of information from watching them play with their toys. Think about, when your own kids have issues or they're angry about something or whatever, and you're watching them play with their toys, you can tell immediately that something's not quite right? Just by the way that they're playing with those toys. It's the same for this. Okay. Any questions, guys? Does that hopefully make sense? Okay, thank you, Ron. All right, here we go. So the last concept I wanted to talk with you guys about today is pain. It is in the pediatric population, just like it would be in the adult population. Again, pain a lot of times is the reason why parents will bring their children in to be checked, because they have an upset stomach, or maybe that they had an injury, they fell, they have a fracture, something, maybe they fell and bumped their head while they were riding their bike and they weren't wearing their helmet, or whatever the case may be. So pain is most commonly a reason why people come for care. And that's no different in the pediatric population. So age. Age always plays a part when we're talking about the pediatric population. Developmental stage. Where are they at on their development? A toddler is going to react to pain much differently than a school-age child is going to react to pain. Sometimes a school-age child may be a little bit more stoic. They're not going to be so emotional when they're having pain as a toddler. A toddler is going to be very emotional. They're going to be very nervous and scared and acting out and crying, and but a school-age child, maybe not so much. Chronic versus acute pain. Generally, children don't have chronic pain unless they have some sort of a health condition that will contribute to that chronic pain. So a child with cancer or some sort of cancer-related disease process, they may have chronic pain. But most of the time, children are going to be having acute pain, something that is self-limited, short-term, and very intense. Prior experiences with pain are definitely going to play into how that child reacts to having pain. What other experiences have they had? Personality. That definitely plays into how they react to pain. The kid's personality. Are they the type that tends to overreact and get very emotional and they have a lot of anxiety and they act out a lot? Or are they the type that tends to be more laid back, more reserved, more easygoing? Because that's definitely going to impact how they react to pain. Again, that family dynamics. Remember, we talked a lot about parenting style. So what type of parenting style are you dealing with when you're interacting with that family? The family dynamics are definitely going to play in to how that child responds to pain. Culture plays in, right? There's a lot of cultures out there that find pain is a weakness. So we don't talk about pain, we don't express pain through our behavior. We're very stoic, we keep it all inside because it shows sign of weakness to actually be showing signs of pain. And that gets, because culture is learned. So that's something that the child learns as they grow in that family. So they may be more stoic when it comes to having pain. Socioeconomic factors. This can also impact how they react to pain. Okay? So all of those factors can influence pain. Before I show the video, I just was going to go through a couple of the scales that we use. So for infants, we use what we call the FLAC scale, which is their face, their legs, activity, consolability, and cry. It's a nonverbal pain scale that we use for the infant population because remember, they don't communicate with us verbally. They communicate through their behavior. So we use that scale to be able to figure out about pain. Cries are different. You have to become attuned to the cry when you work in pediatrics. A pain cry is going to have a very different pitch and tenor than a cry because they're hungry or because they need to be changed. Okay? For your toddler, there's a couple of different scales that we can use for them. One is called the Oucher scale, and the other one is the Wong-Baker Faces scale. Now, their cognitive development, they really don't understand what 0 to 10 means. So a number scale is not going to work for a toddler. But they can look at the face. You can say, show me, point to your face. Which face is how much pain you're having right now? How much is the owie, right? And they can point to a face. So that they can do. But as far as numbers, that's not going to translate to a toddler or even to a preschooler. They don't really understand that concept. But when they get into that school age, 7, 8, 9 years old, they can understand what numbers mean. But it doesn't hurt to use the Wong-Baker scale. I used the Wong-Baker scale even with adults because sometimes adults don't understand what a pain of 5 is. It means something different to them than it does to you. So if you use the faces, sometimes that helps them to understand how much pain they're really having, as opposed to a number. Okay? Does that make sense? There's a lot of different scales. I just wanted to point out those few. There's several other scales that can be used. Wong-Baker was the one most commonly used in my facility. Every facility has a different type of scale that they use, but they all pretty much work the same way. It's just important that we as the nurses understand how that scale works and what information it is that we're trying to get out of that scale. That's what's important. Okay, I'm going to show this video. This is another short video. Hang on. Let me pull it up here. I've got to unplug myself again.
Children's Hospital Los Angeles is known for its compassionate and knowledgeable world-class nursing staff. Nurses are the eyes and ears of the hospital, our patient advocates, and they are at the bedside 24/7. They know every procedure a child has had, they know how to calm a worried parent, and they know how to ease a child's pain. We'll meet 2 nurse practitioners who are at the forefront of pain management, an emerging specialization in the nursing field. Children's Hospital Los Angeles boasts a staff of over 900 nurses dedicated to world-class pediatric care. Children's Hospital supports staff that have a vision for improving patient care. So in 1998, the hospital stood behind a group of nurses that wanted to dedicate 100% of their time to understanding and managing children's pain. It was then that the pain management team was born. Nurse practitioners Debbie Jury and Megan Middleton have advanced degrees in nursing and pain management. They lead the hospital in comforting children who are in severe pain, be it from treatment or surgery.
The goal of pain management is to provide pain relief with the minimal amount of side effects.
The field of pain management for children is relatively new.
In the early 90s, even, kids were undergoing circumcisions and hernia repairs and hydrocele repairs that were considered small surgeries without any type of analgesics. And then they started looking at the nervous system and how children develop. And they found out that children actually have more pain than adults. And that a 6-month-old has about 5 times the amount of pain that an adult has. And a 1-year-old has about 3 times the amount. And even up to the age of 5, they still have about double the amount of pain that an adult has.
With children especially, I think coming to the hospital is a fearful experience. They're surrounded by strangers who are asking them in-depth questions, wanting to look at them and touch them. So the whole experience for children can be scary, and if you add to that pain, can really set up a future aversion to medical care.
17-month-old Christopher just underwent surgery.
The great thing about this case is that they were able to do a regional block in the operating room that will provide pain relief for anywhere from 12 to 24 hours after surgery.
A regional block is an injection of an anesthetic along the nerve. Local anesthetics, such as this, reduce the amount of morphine or other narcotics a child needs.
It's much like when you go to the dentist, and the dentist will numb the area of your mouth where they're filling your cavity.
Dr. Giovanni Pucciaro is the director of the Comfort Pain Management and Palliative Care Program and an anesthesiologist.
By using ultrasound, we can clearly see the needle advancing towards the nerve, and we can inject the local anesthetic not in the nerve, but around the nerve.
So that's an example of minimizing the amount of medications that Christopher will need over the next day while still controlling his pain.
Megan explains the plan for managing Christopher's recovery to his parents.
During the operating room, he got some morphine that should last until later today. He had a caudal block. So hopefully until later this afternoon, he should be nice and comfortable.
Christopher's parents can sit by their son's bedside with ease, now knowing that he will wake up without pain. The pain management team also works in the neonatal intensive care unit. Here, they are challenged to comfort the smallest patients who cannot verbalize their discomfort.
We're working with small, extremely premature babies who most of them have varied procedures. So our job is to treat these babies who can't tell us where necessarily they're hurting.
If they have a furrowed brow where they're pulling their eyebrows in and they're crying and they're inconsolable and they have clenched fists, and then we know the vital signs are increased, that they have an increased heart rate and an increased respiratory rate, then we know that it's more than just a diaper change or feeding, that they're actually having pain.
Because many families worry about the side effects of most medicines, Children's Hospital Los Angeles strives to give maximum comfort with minimal medication. To do this, they offer alternative therapies.
The last 10 years, the biggest change in pain management is all children were getting injections if they had pain. Now, very few children ever see a needle in order to manage pain. We give a lot of drugs through the IV. We give a lot of drugs orally. We have patches now.
At Children's Hospital, one dose of comfort comes from a furry, friendly face.
Kids come into the hospital and they miss their dogs. And so we brought the dogs in, and then we found that the benefit of bringing the dogs wasn't just for them to see a dog. They're used for distraction therapy. They start paying attention to the dog, and they don't realize that they have an IV being started.
But the pain management team also uses massage and acupuncture to reduce medicines and increase comfort.
So I can see the difference that I'm making. I walk into a patient's room that's having pain, oftentimes can make a few adjustments that really solve the problem.
And usually within 24 hours of seeing the child, there is a 50 to 100% improvement in the pain. And it's so rewarding. The families are happy, we're happy, the kids are happy, because the whole thing about a child is they're meant to play. That's their work of life, is to play. And if they're laying in bed, they're not seeing a child. And we want them to get back to feeling good. And it's so rewarding to walk into a room where you see a child that's been crying, and the next day you walk in and you see the child laughing, and the family's happy, and we're happy, and it's a great show.
Okay. All right. The reason why I showed that video is because it just kind of gives you a little bit of understanding of how integral our role is. The nurses that they were talking to in the video were nurse practitioners, but they're still nurses, right? So the nurse plays an integral role in helping the family and the child adjust to that hospitalization environment. Used to be, the thought process was kids didn't really feel pain, or if they did, it wasn't as bad. So, and a lot of times the providers would shy away from giving them opiates because they just weren't comfortable. They were more concerned about side effects. And so it took a lot. And nurses actually were the spearheads of getting this pain management to where it is today. It wasn't providers, it was nurses. So just so you know, we have a very important role in no matter what practice setting that we're in. We do have a very important role, and that's all part of being that patient's advocate or that family's advocate. Okay, guys, well, that's all I got for you today. Does anybody have any questions about anything I talked about today? I'll make sure to go through the chat. I know several of you had put things in the chat. I'll make sure that I go through it and see if there was any questions that I didn't get to. Okay, well, thank you guys so much for coming. I will be posting this recording as soon as it's available, just so you know. I'm going to go ahead and stop that. Hit the stop.